بسم الله الرحمن الرحيم. صباح الخير، منورين ودايما كل سنة منورين. هنبدأ راديولوجي السيشن بتاعتنا النهاردة. دكتورة شريهان وحيد موجودة. Her presentation is from detection to decision, imaging challenges in high-risk breast lesions.
Bismillah ar-Rahman ar-Rahim. Our talk today was about high-risk breast lesions. What are B3 lesions? These are lesions of uncertain malignant potential that we frequently encounter in our core needle biopsy results. The goal today... No. The goal today is to demystify this category, understand the risk of each lesion, and define our critical role in managing these patients. These lesions can be considered as a yellow light. مظبوط كده؟ مظبوط؟ صوت مظبوط؟ These lesions can be considered as a yellow light from the pathologist. It's not cancer, a red light, and not malignant, a red light, and not clearly benign, a green light either. It tells us that the sample tissue has features that put the patient at a higher risk for having or developing breast cancer, and that the entire area needs a proper evaluation. The B3 basket includes atypical ductal hyperplasia, lobular neoplasia, fibroepithelial lesions, papillary lesions, flat epithelial atypia, radial scar, and other miscellaneous lesions such as spindle cell tumors. Starting with atypical ductal hyperplasia, this is the classical B3 lesion. The imaging, especially calcifications, is the reason for the biopsy. There is no reliable way to distinguish ADH from DCIS on imaging, which is why excision is mandatory when the core needle biopsy shows ADH. The commonest presentation is calcifications, which may be pleomorphic, amorphous, or fine linear, and are more likely grouped. On ultrasound, it may appear as a hypoechoic mass with irregular margins and may show posterior shadowing. On MRI, it may appear as an irregular mass or non-mass enhancement, and this should be correlated with the calcifications. Surgical excision is the gold standard and remains mandatory in most cases. Vacuum-assisted excision with surveillance is only considered in highly selected cases with strict criteria and MDT agreement. These strict criteria include that there's complete radiological target removal, a larger needle is used, and more than 12 lesions are sampled. More than 12, samples are taken from the lesions. In this case, we have a 50-year-old complaining of a right breast lump. On mammography, an irregular speculated dense mass with overlying pleomorphic calcifications is seen in the right upper outer quadrant. The calcifications are seen extending 31 millimeters beyond the mass in a linear configuration and stopping 57 millimeters away from the nipple. On ultrasound, we have an irregular isoechoic mass with a speculated margin and internal flex of calcifications with a similar lesion seen nearby. The true cut biopsy came back as a granulomatous reaction, which was obviously discordant with the radiological images. Wide local excision was done, and this was upgraded to atypia, ADH with atypia. Moving on to the second lesion, we have the lobular neoplasia spectrum, which includes atypical lobular hyperplasia and lobular carcinoma in situ. Pathologically, they are differentiated by the percentage of SNI involvement. They have an 8 to 10-fold increased risk of invasive breast cancer and bilaterality in up to 60% of the cases. They have a variable presentation from occult to extensive disease, with occult presentation being the commonest, representing around 60 to 80% of the cases. They may show calcifications or architectural distortions. The lobular neoplasia is often is labeled the surprise B3 lesion. The key point is that if the biopsy was done for a mass or distortion and lobular neoplasia is the only finding, then this is likely discordant. The radiological target was properly missed and excision is needed to sample the correct area. Management is entirely dependent on concordance. For example, if it's discordant, excision is mandatory. If it's concordant or incidental finding on biopsy, then vacuum-assisted excision or surgery can be considered. In this case, we have a 40-year-old complaining of bilateral breast lumps. The only noticeable finding in these dense breasts are the bilateral diffuse scattered macrocalcifications and microcalcifications that are mounting to groups in both upper outer quadrants. Complementary ultrasound shows diffuse heterogeneous background parenchymal echo texture with dense fibroglandular tissues corresponding to palpable areas with no underlying definite masses. PEM was performed, and it shows bilateral, extensive, irregular, non-mass uptake, which shows high avid reading, and is more evident on the right side. The surgical biopsy came back as the true-cut biopsy first came back as lobular carcinoma in situ, and this was later upgraded on surgery to show an invasive component. Our third B3 lesion is the flat epithelial atypia. This is it's becoming increasingly recognized as a B3 lesion, and is usually presents as often coexists with ADH, DCIS, or tubular carcinoma. It usually presents as calcifications, and the calcifications are usually considered low suspicion. They are usually grouped or clustered amorphous microcalcifications. Ultrasound may show an associated hypoechoic area, and MRI may show non-mass enhancement with clumped linear distribution. The management of flat epithelial atypia is shifting. If the initial biopsy completely removes the calcifications, surveillance is a strong and increasingly accepted option. If there is a residual target, surgical excision is then recommended. In this case, we have a 35-year-old with positive family history who's coming up to follow on right breast BIRAT3 lesion. The mammography revealed upper outer quadrant regional amorphous calcifications as well as round calcifications that are seen in the left breast, as well as a right upper outer quadrant posterior third partially obscured isodense lesion. And this is a close-up view of the calcifications that were noted. Ultrasound revealed no suspicious masses that correspond to the area of calcifications, and the right breast lesion was considered as a benign-looking lesion. Biopsy was done, and it came back with only one focus of flat epithelial atypia. Wire localization was then recommended, and this showed a whole area of atypical epithelial atypia and PASH, and that this was negative for malignancy. The other B3 lesion that we'll be discussing is the radial scar or the complex sclerosing lesion. It has a very characteristic radiological and pathological appearance, and it has a higher upgrade if it's associated with atypia. The imaging characteristics, as I said, are very specific. It usually presents as architectural distortion with a central radiolucency and may contain calcifications. By ultrasound, it shows as an irregular hypoechoic area with posterior shadowing or architectural distortions. And by MRI, it might appear as an enhancing mass with irregular margins and speculations. Surgical excision is the historical and still predominant standard due to its speculated appearance and risk of associated malignancy. However, vacuum-assisted excision is an emerging option only if no atypia is present and the lesion is completely removed. We have a 41-year-old who's coming for screening, and we can see a left breast upper inner speculated lesion that measures about 5 centimeters. بس في دولت فيديو. These are the tomosynthesis images of the CC view, and we can see that the distortion is clearly displayed here. And this is the MLO view. Again, we can see the distortion clearly appreciated. By ultrasound, there was an area of parenchymal distortion mounting to a speculated hypoechoic mass formation. True-cut biopsy revealed radial scar, and the wide local excision confirmed the pathology. Moving on to a group of the fibroepithelial lesions, or what is known as the biphasic tumor. These are a group of tumors composed of epithelial and stromal components. They represent a spectrum from benign to malignant. The fibroadenoma represents the B2 lesion of the spectrum. The benign and borderline phylloids represent the B3, while the malignant phylloids represents the B5 spectrum. The classifications of the phylloids tumor is based on histological features. The benign will have mild stromal atypia and low mitotic activity. The borderline will have moderate stromal and intermediate mitotic activity, while the malignant phylloids will have a marked stromal atypia and high mitotic activity. From a clinical perspective, the most important red flag that you'll hear from a patient or see on prior imaging is rapid growth. On ultrasound, they can mimic a fibroadenoma. However, you should be suspicious of any large growing mass, especially one that shows heterogeneous texture or in cystic spaces. Describing these features specifically in your report is crucial. On the core needle biopsy, a diagnosis of fibroepithelial lesions or phylloid tumor cannot be excluded is the classical B3 scenario. The pathologist cannot guarantee it is not a phylloid tumor due to the limiting sampling. Going from beyond the simple fibroadenoma to the more complex fibroadenoma. When do we suspect a complex fibroadenoma? It's when a simple fibroadenoma contains one or more of the following: either sclerosing adenosis, papillary apocrine metaplasia, epithelial calcifications, or cysts that are more than 3 millimeters. And they represent a risk factor of 2 to 3-fold increased risk of breast cancer. The presence of these features alone does not automatically make it a B3 lesion. In many cases, a concordant complex fibroadenoma can still be managed as a B2 lesion. The diagnostic and clinical challenge arises when you find atypia within or associated with this complex fibroadenoma. On imaging features, it's often you can't really distinguish it from a simple fibroadenoma. They may appear more heterogeneous due to the cysts or the sclerosis. They may contain coarse or popcorn calcifications, and by ultrasound, they present as hypoechoic mass with internal cysts and vascular flow. When does a complex fibroadenoma become a genuine B3 concern? The key is the presence of atypia. If a core biopsy of a complex fibroadenoma incidentally finds cells of ADH or lobular neoplasma, the management immediately escalates. The finding is no longer just a complex fibroadenoma, it is now ADH associated with fibroadenoma, and that ADH component is a B3 lesion that mandates surgical excision. Long-term surveillance, even without atypia, can be also done. And why do we perform wide local excision, especially with phylloid tumor? And this is to establish a definitive diagnosis of the entire lesions, because negative margins are critical to prevent local recurrence. In this case, we have a 40-year-old complaining of a left breast lump, and the mammography shows the left breast retroareolar and lower inner quadrant lobulated mass lesions. By ultrasound, we have a corresponding large lobulated interconnecting heterogeneous lesions showing internal vascularity. The true-cut biopsy came as a spindle cell lesion and with consideration for a borderline phylloid tumor, and excision was recommended. On wide local excision, it came back as actually as a phylloid tumor and a malignant one. In this case, we have bilateral few scattered isodense lesions that are noted in both breasts, and the left upper inner quadrant shows heterogeneous calcifications. By ultrasound, We have at left breast, 12 o'clock, oval-shaped hypoechoic lesion with microlobulated outlines and internal calcific foci with no appreciable internal vascularity. Biopsy was done, and this came back as a sclerosing adenosis. In this case, we have a 45-year-old who's been coming for screening for the past 3 years, and we noticed that there's a deeply seated mass that's increasing in size. Ultrasound also revealed the progression in size. And this came back as a papillary apocrine metaplasia with a suspicious area, which was later then upgraded to an invasive lobular carcinoma. Quickly moving on to the papillary lesions. These are lesions that represent 1 to 3% of all breast lesions, spanning from a benign to malignant spectrum with distant radiological and pathological characteristics. They usually present as...
Conclusion, please, Doctora.
There's a papillary lesions. I'll quickly show us the cases. This is a 50-year-old coming for screening with history of intermittent bloody nipple discharge. The left upper outer quadrant shows area of focal asymmetry. By ultrasound, we have multiple dilated retroiliac ducts with multiple intraductal echogenic vascular components. And this was a case of intraductal papillary neoplasm. Moving on quickly, what are the imaging modalities that we can use for B3 lesions? We have the mammography, ultrasound, and breast MRI. We can also use the advanced MRI techniques such as the abbreviated breast MRI, diffusion-weighted imaging, or PET MRI. We can also use the contrast-enhanced mammography, tomosynthesis, and molecular imaging, while also incorporating AI in our workflow. The most critical step after a B3 core needle biopsy is the multidisciplinary team review, which includes the pathologist, breast surgeon, radiologist, and oncologist. The most critical step is the concordant case and discordant case. The questions that we have to ask: does the pathology account for the imaging features? Was the biopsy sampling adequate? And was the lesion correctly targeted? The key to managing B3 lesions lies not in treating every lesion aggressively, but in understanding the individual risk profile and making evidence-based decisions through multidisciplinary collaboration. Thank you.
Thank you very much, dear Shirihan. You have very nice cases, really. And I think we wanted to speak more, but the time is out. And now Dr. Minnatullah Hanafi, she will present us the speech about the invasive lobular carcinoma, diagnostic pearls across modalities. Invasive lobular is always a dilemma. So we can see what we can do.
Invasive lobular carcinoma, diagnostic pearls across modality. The invasive lobular carcinoma is characterized of being the second most common subtype of invasive breast cancer with maximum incidence in postmenopausal women and higher incidence of multiplicity and multicentricity, multifocality, and contralateral disease. The reported sensitivity of mammography for detection of invasive lobular carcinoma range from 57% and 81%. The hallmark of invasive lobular carcinoma is loss of expression of E-cadherin, which is a transmembrane protein responsible for cell-to-cell adhesion. Loss of cis function results in a distinctive, diffuse growth pattern without inducing significant desmoplastic reaction, making the detection of the disease and definition of its extent sometimes radiologically challenging. Clinically, invasive lobular carcinoma usually fail to form a palpable mass and manifests clinically with vague or absent clinical finding. The gross picture of invasive lobular carcinoma is commonly irregular mass with ill-defined borders, sometimes grossly indeterminate or only felt as a slight palpable firmness. The histopathological variants of invasive lobular carcinoma are classic pattern, which is the most common, pleomorphic pattern, tubular lobular pattern, solid pattern, and alveolar pattern. The classic variant is the most common, where the tumor cells are small monomorphic arranged in single files or concentrically around normal ducts. While pleomorphic variant is clinically and radiologically aggressive, where tumor cells are of high grade and of different size. The tubular lobular variant is arranged as small tubules or admixed with classic pattern. The solid pattern is formed of sheets of tumor cells, while the alveolar pattern cells are arranged as small groups within alveoli. Then, the mammographic feature of invasive lobular carcinoma. The most common mammographic presentations are distortion, as in this case, left upper outer quadrant distortion, pathologically proven invasive lobular carcinoma, speculated mass lesion, asymmetry, as in this case. The less common mammographic presentations are circumscribed mass or suspicious microcalcifications, as in this case there was right breast suspicious amorphous microcalcifications. For the ultrasound features of invasive lobular carcinoma, the most common ultrasound presentations are irregular mass lesions and altered parenchyma. Yet, sonomammographic features of invasive lobular carcinoma may be very subtle, as in this case, 65-year-old presented by nipple discharge. At first, no definite abnormality could be detected, yet upon zooming, left breast outer quadrant subtle distortion is detected by ultrasound corresponding to focal shadowing, which is corresponding by contrast mammography to left breast upper outer quadrant irregular, faintly enhancing small speculated lesion given by RAS4, yet there is moderate background parenchymal enhancement. So MRI was performed, confirming the presence of left breast upper outer quadrant segmental enhancing foci. Wire localization was performed, and the pathology was invasive lobular carcinoma grade 2 classic and pleomorphic pattern. In this case, 44-year-old patient came for screening. Her mammography showed no definite abnormality detected. Yet contrast-enhanced mammography and MRI showed right breast outer central irregular homogeneously enhancing mass of moderate intensity with type 3 washout curve by MRI. And the pathology was right unifocal invasive lobular carcinoma grade 1. Regarding the low sensitivity of mammography for invasive lobular carcinoma and higher incidence of multiplicity and bilaterality, this led to generated interest in contrast-based studies, MRI, and contrast-enhanced mammography for detection of the lesion and for staging to detect a size assessment, multiplicity, and bilaterality. Dynamic MRI and contrast-enhanced mammography usually show invasive lobular carcinoma as mass, non-mass, or enhancing foci or more than one enhancement pattern. The study performed 2024 about the performance of contrast mammography and MRI in invasive lobular carcinoma, published by our professors, Dr. Rashad, Dr. Umnaya Mukhtar, and Dr. Shari Fakhri, regarding intensity of enhancement in dynamic MRI and contrast mammography. The MRI showed significant higher intensity of enhancement in invasive lobular carcinoma compared to contrast mammography. As in this case, 53-year-old patient came for screening. Her mammography showed left breast central asymmetry, showing faint non-mass enhancement, yet the MRI showed intense non-mass enhancement. They concluded that the most sensitive imaging modality regarding detection of index lesion is the MRI, and it's more sensitive for detection of multiplicity and bilaterality owing to conspicuity of the lesion enhancement as compared to contrast mammography. However, if MRI examination couldn't be performed, then contrast-enhanced mammography can be a good, reliable alternative. In this case, 47-year-old patient presented by left breast lump. Her mammography showed left upper central dense speculated mass, By ultrasound, there was a left breast 12 o'clock speculated hypoechoic mass lesion given by REST-4C, and the biopsy result was left breast invasive lobular carcinoma grade 2. Both contrast-enhanced mammography and MRI were comparable in this case, showing left upper central speculated heterogeneously enhancing mass with adjacent tiny satellites. And the final pathology was invasive lobular carcinoma multifocal grade 2. So our take-home message that dynamic contrast-enhanced MRI is the most sensitive imaging modality regarding detection of index lesion, multiplicity, and bilaterality. However, contrast-enhanced mammography could be a good, reliable alternative. A 53-year-old patient came for screening. Her mammography showed right breast upper outer quadrant architecture distortion given by REST-4 with no definite left breast suspicious lesion at first. Her ultrasound showed right breast upper outer quadrant multifocal area of distortion with posterior shadowing, while the left breast showed few small cysts with no definite suspicious ultrasound findings. Ultrasound guided biopsy of the right breast lesion was invasive lobular carcinoma grade 2. MRI was performed, revealing right breast multicentric focal non-mass enhancement and enhancing foci, while the left breast multicentric focal non-mass enhancement and enhancing foci given by REST-4. So second look on mammography revealed subtle retraction in left CC view, with yet no definite suspicious lesions by ultrasound. A vacuum-assisted biopsy was performed from left breast upper outer quadrant area corresponding to non-mass enhancement seen adjacent to ultrasound, and MRI detected small cyst, revealing fibrocystic chains with atypical ductal cells. Bilateral modified radical mastectomy were performed, revealing bilateral multicentric invasive lobular carcinoma grade 2 classic variant. A 57-year-old patient came for screening. Her mammography showed right breast upper outer quadrant axillary tail subtle distortion. Contrast-enhanced mammography showed right upper outer quadrant focal heterogeneous non-mass given by REST-4, and ultrasound showed right breast axillary tail focal ultrasound shadowing and subtle distortion. So biopsy was taken, and it was invasive lobular carcinoma grade 2 classic type luminal A. So our take-home message in this case, sonomammographic features may be very subtle. Dynamic MRI, breast and contrast-enhanced mammography improved diagnosis and preoperative staging. 49-year-old patient presented by palpable lump. Her mammography showed left breast lower central focal asymmetry corresponding to ultrasound to left breast 7 o'clock altered parenchyma mounting to mass formation with ipsilateral non-specific looking axillary lymph node by REST-4. Biopsy was taken, and it was invasive lobular carcinoma grade 1 luminal A. Contrast-enhanced mammography showed lower central irregular speculated heterogeneously enhancing mass lesion with adjacent satellites. The post-operative pathology showed invasive lobular carcinoma tubulolobular pattern with metastatic positive sentinel lymph node being discordant with ultrasound, which showed non-specific lymph node. So our take-home message in this case, invasive lobular carcinoma has an increased incidence of non-specific looking axillary lymph node by ultrasound, which proved to be metastatic post-operative. Also, invasive lobular carcinoma has increased risk of extensive axillary lymph node metastasis compared to invasive duct carcinoma. 49-year-old patient with history of right conservative breast surgery. The current mammography compared to the previous showed left breast upper outer quadrant subtle developing asymmetry given by REST-4 corresponding to 12 o'clock subtle area of altered parenchyma. So MRI was performed revealing left breast distorted parenchyma with intense focal non-mass enhancement given by REST-4, and the final pathology was invasive lobular carcinoma grade 2 associated with LCIS. So our take-home message in this case, comparison with previous radiological studies and follow-up are essential. In this case, 50-year-old patient presented by right breast lump. Her mammography showed right upper outer quadrant focal asymmetry corresponding to 9 o'clock altered parenchyma by ultrasound. And the biopsy was right invasive lobular carcinoma. PEM was performed revealing the biopsy of the right breast was right invasive ductal carcinoma grade 2. The PEM was performed revealing right breast hypermetabolic lower outer quadrant small irregular lesion with uncircumscribed margin with PUV uptake 5.6 and LTP 10, while the left breast showed lower outer quadrant low metabolically active segmental non-mass uptake. Final pathology of the left breast was unifocal invasive lobular carcinoma grade 1. In this case, the left breast invasive lobular carcinoma showed lower uptake compared to the right invasive ductal carcinoma malignant process. So our take-home message in this case, the addition of PEM to conventional imaging is associated with increased sensitivity and accuracy in depicting breast lesion, local staging, and surgical planning, PEM offering an acceptable alternative in MRI patients who cannot tolerate or have contraindication to MRI as renal failure. Invasive lobular carcinoma show lower FDG uptake compared to invasive ductal carcinoma in PEM study. 51-year-old patient came for screening. Her mammography showed right breast lower inner quadrant well circumscribed, fat-containing mass lesion, suggestive of hamartoma with associated internal small speculated lesions. So it was given by RAS4. Tomosynthesis confirmed these speculated lesions within well-circumscribed mass lesion, and the ultrasound showed right breast lower inner quadrant well-circumscribed mass lesion of mixed echogenicity suggestive of hamartoma with internal speculated lesion. Biopsy was taken, and it was invasive lobular carcinoma grade 2 classic variant. Right simple mastectomy was performed, revealing multifocal invasive lobular carcinoma grade 2 arising within the background of breast hamartoma. So our take-home message in this case, invasive lobular carcinoma can even coexist within a hamartoma. The last case, 30-year-old patient presented by bilateral palpable lump. Her ultrasound showed bilateral palpable area of parenchymal condensation with subtle alteration. MRI was performed, revealing bilateral multicentric, multi-regional non-mass enhancement, pathologically proven invasive lobular carcinoma grade 2 luminal A. FDG PET-CT was performed, revealing widespread osteosclerotic deposit, yet with low SUV max. SUV max was 3. So our take-home message in this case, metastatic invasive lobular carcinoma is less FDG uptake compared to invasive ductal carcinoma. Like invasive ductal carcinoma, invasive lobular carcinoma can metastasize to bone, lung, liver, thoracic and abdominal lymph nodes and brain, but it can also spread to unusual sites as gastrointestinal tract and reproductive organs. Finally, I'd like to thank Dr. Mahitab Touhani, pathology consultant at Bahia Hospital, for her contribution with pathological images in this lecture. Thank you.
Thank you, Dr. Minnatullah, for your nice presentation. And now, Dr. Mahmoud Mekhimer. Yes, the lecture is about beyond the index lesion, PEM, and challenge of multiplicity in breast cancer. Please, Dr. Mekhimer, stick to the time.
Bismillah ar-Rahman ar-Rahim. Beyond the index lesion, PEM and the challenge of multiplicity in breast cancer. Breast cancer is a global health problem. Proper management requires an accurate diagnosis regarding the size, multiplicity, and bilaterality. In the past few years, the volume of breast imaging modalities have grown exponentially, and thus implementing sound practice has become a real challenge. Different breast imaging modality can assess morphological information as mammography, 3D tomosynthesis, and ultrasound, or can assess functional information as diffusion-weighted images, spectroscopy, or can combine both morphological and functional information as dynamic contrast, MRI, contrast-enhanced sonomammography, and positron emission mammography. PEM involves the use of FDG for the detection of glucose metabolism by breast cancer cells, so it is considered a functional imaging modality. FDG is transported inside the cell through glucose transporter 1 receptor, then it becomes phosphorylated and then become trapped inside the cell and can be transported out of the cell, leading to accumulation in the malignant cells. BIM images can be viewed in different color scale, the gray scale, the negative scale, or the hot iron scale. BIM is indicated in indeterminate breast lesion as a complementary tool to mammography and ultrasound. Indeterminate breast lesion in patient with dense breast and contraindication to MRI as claustrophobia. In patient with renal insufficiency as the contrast can't be given to the patient, or initial staging evaluation of breast cancer patient, either multifocal or multicentric disease, but not for the axillary lymph node staging. BIM can differentiate recurrent carcinoma from scar tissue. Also, BIM can monitor response to the neoadjuvant chemotherapy. Advantage of BIM, it has higher spatial resolution than BIT. It can detect small cancers up to 2 milli and lower grade lesions. It is used as an alternative to MRI in newly diagnosed patient when MRI is contraindicated. BIM images can be correlated with those of mammography in case of equivocal increased FDG uptake on areas of normal fibroglandular density. Also, BIM can predict tumor aggressiveness. The disadvantage of BIM can be grouped into false positive result, can be due to infection, inflammatory process, or recent post-operative changes. Benign lesions such as fibrocystic disease or fibroadenoma, especially during its rapid growth phase, and also in the increased breast density. False negative result can be due to lesions outside the field of view, lesion in the posterior aspect of the breast, or lesions close to the chest wall, and lesions in large breast. Also, lobular carcinoma have decreased vascularity and decreased metabolic activity. The radiation exposure of BIM, BIM has 15-fold higher risk of cancer induction compared to single digital mammography. Also, in BIM, the whole body organs are exposed to radiation, unlike mammography, where the breast is the only exposed organ, so it is unlikely to be used for screening. BIM interpretation can be qualitative, similar to MRI, or quantitative, similar to BIM, similar to BIT. In this case, we assess BOV max, BIM uptake value, and also the lesion to background LTB. Lesion showing radiotracer uptake can be focus, which is tiny uptake less than 5 millimeters, too small to be characterized morphologically, or mass 3-dimensional lesion with specific shape and FDG uptake pattern, or non-mass tracer uptake in an area different from the normal surrounding parenchyma, but not foci or masses. This is focus uptake in invasive duct carcinoma, this non-mass uptake in invasive duct carcinoma, and this focus uptake in invasive lobular carcinoma. Tumor size is a primary prognostic factor for breast cancer and inversely affect the breast cancer survival rate. The larger the tumor, the higher the stage, and the lower the 5 survival rate. Differentiating multifocal and multicentric disease is important as it affects the surgical management. For quantitative approach, quantitative assessment, the first row is placed over the lesion to assess BOV max of the lesion. Then the second row is placed over the normal parenchyma to assess main background of the parenchyma. Then the LTB is calculated as BOV max of the lesion over the mean background of the parenchyma. This is a 61-year-old female patient with renal failure complaining of left breast lump. Mammography revealed left breast upper outer quadrant dense speculated lesion, and also right breast lower inner deeply seated dense speculated lesion. Biopsy revealed left invasive duct carcinoma grade 1 and right invasive duct carcinoma grade 2. BIM was the only available modality and revealed right breast deeply seated partly seen outfield of view single malignant mass lesion with BOV max 1.9 and LTP 3.24, while in the left breast, in the left breast, there is multicentric malignant bruises, including FDG avid mass, foci, and non-mass uptake, with BOV max 4.6 and LTB 8. This 45-year-old female patient complaining of right breast lump. Mammography revealed heterogeneously dense breast. Complementary ultrasound revealed right breast retroareolar irregular hypoechoic lesion at the site of the patient concerned. Biopsy revealed right breast invasive duct carcinoma grade 3. BEM was done and revealed right breast retroareolar multifocal malignant mass and foci with BOV max 9.6 and LTB 11.3. This is a 33-year-old female patient with left breast lump. Mammography revealed left breast upper outer quadrant 12 o'clock dense speculated lesion. Biopsy revealed left breast invasive tubular carcinoma grade 2. BEM was ordered and revealed left breast multifocal malignant process including FDG avid mass and foci with BOV max 3.8 and LTB 4.5. This is a 48-year-old female patient complaining of left breast lump. Mammography revealed left upper outer quadrant isodense, partly obscured mass lesion with polymorphic calcification. Sonar ultrasound revealed invasive duct carcinoma grade 3. Contrast was ordered and revealed left upper outer quadrant deeply seated heterogeneously enhancing mass lesion and also anterior non-mass enhancement and upper outer quadrant ring enhancing complicated cyst, while in the right breast it revealed upper inner quadrant non-mass enhancement. BEM was ordered to assess the nature of these non-mass enhancing lesions. BEM revealed left breast single invasive duct malignant FDG avid lesion with BOV max 10.9 and LTB 11.15, while in the right breast it revealed faint upper inner quadrant non-mass enhancement with BOV max 1.6 and LTB 1.5. VAB was ordered from the right breast faint non-mass uptake and revealed right breast fibroadenosis and fibrocystic with no malignancy. This is a 49-year-old female patient complaining of left breast lump. Mammography revealed left upper quadrant dense speculated lesion and also skin thickening. Complementary ultrasound revealed irregular hypoechoic lesion. Biopsy done and revealed invasive lobular carcinoma grade 2. So MRI was ordered and revealed left breast upper outer quadrant and retroareolar heterogeneously enhancing mass lesion and surrounding few enhancing foci. Also, few enhancing foci were detected in the right breast. BEM was ordered to assess the nature of these enhancing foci. BEM revealed left breast upper outer quadrant non-mass FDG uptake with BOV max 2.5 and LTB 4.6, while in the right breast, few faint FDG uptake by small foci with BOV max 1.2 up to 1.5 and LTB 2 up to 2.4. In this case, this is a 61-year-old female patient complaining of left breast lump. Mammography revealed left upper quadrant deeply seated dense speculated lesion and biopsy revealed invasive duct carcinoma grade 2. MRI was done and revealed upper outer quadrant left breast heterogeneously enhancing mass lesion and also few surrounding enhancing foci, while in the right breast, few enhancing foci were detected as well. BEM was ordered to assess the nature of these enhancing foci and revealed left breast upper outer quadrant FDG avid malignant mass lesion with BOV max 8.1 and LTB 16.5. Also, it detected in the left breast lower inner quadrant FDG avid focus with BOV max 1.8 and LTB 3. Second look ultrasound for this FDG avid focus was done and revealed small irregular lesion. Biopsy revealed left breast invasive duct carcinoma grade 2. This is a 71-year-old female patient with history of renal failure and coming for screening. Mammography revealed bilateral upper outer quadrant dense speculated lesions. Biopsy revealed right invasive duct carcinoma grade 2 and left invasive duct carcinoma grade 3. BEM was ordered, revealed right breast multicentric malignant bruises in the form of FDG avid foci, masses and non-mass uptake with a BUV max 4.3 and LTB 7.4, while in the left breast, single FDG avid malignant mass lesion with BUV max 6.1 and LTB 10. This is a 57-year-old female patient coming for screening. The mammography revealed right breast lower outer quadrant dense speculated lesion. Biopsy revealed invasive duct carcinoma grade 2. Contrast was ordered and revealed right upper inner quadrant heterogeneously enhancing mass lesion and also view surrounding enhancing foci. The overall occupied area was 9 multiplied by 7, but the patient was concerning conservative breast surgery, not mastectomy. So BEM was ordered to assess the nature of these enhancing foci and revealed right breast lower outer quadrant dense FDG avid malignant mass lesion with BUV max 1.9 and LTB 4.3. It also revealed lower inner quadrant FDG avid focus with BUV max 1.2 and LTB 3.1. Second look ultrasound was done for this focus and revealed small irregular hypoechoic lesion. Biopsy revealed polymorphic lobular carcinoma inside. Take-home message: BEM can play a substantial role in assessing the disease extent in newly diagnosed breast cancer patients, especially in women seeking the conservative breast surgery. BEM can detect lesion size very accurately with result close to the post-operative pathology result. BEM demonstrates great accuracy in assessment of the tumor multiplicity and disease extent. Also, BEM can predict tumor aggressiveness. The higher the grade, the higher the uptake. Finally, BEM shouldn't be used as a standalone examination. Instead, it is used as complementary examination to mammography and ultrasound. Thank you.
Thank you, Dr. Mahmoud, for the nice presentation. And now we will go to the next one. Dr. Salwa Yahya, she will talk about the advanced MRI brain interpretation, non-mass enhancement, diagnostic challenges, and the clues.
السلام عليكم ورحمة الله وبركاته. أنا بس حابة يا جماعة أفكركم عندنا دلوقتي 2 workshops شغالين في الدور الثاني في الوركشوب اريا اللي هي نيو ادجفنت كيموثيرابي، والثانية اللي هي الكونتراست انهانسد ماموجرام فيرسس ام ار، فاللي حابب بقى يشترك فيها. النيو ادجفنت وركشوب هتبقى النهارده بس. بسم الله الرحمن الرحيم. Advanced MR interpretation, non-mass enhancement, diagnostic challenges and clues. Non-mass enhancement means parenchymal area of abnormal asymmetrical enhancement without a space-occupying lesion. It's common, but its interpretation is difficult due to the overlapping benign and malignant causes, critical for detecting DCIS and subtle invasive cancers. Interpretation depends on distribution and internal enhancement pattern. It influences biopsy decision, surgical planning, and patient anxiety. المايك أقربه ولا؟ Diagnostic challenges: overlapping appearance, high inter-reader variability, technical limitations, hormonal background, parenchymal enhancement, and MR-only lesions. Overlapping appearances between benign, including hormonal, fibrocystic changes, mastitis, post-operative changes, versus malignant as DCIS and invasive carcinoma. Distribution and pattern can be non-specific. High inter-reader variability. Radiologists often disagree on a suspicious level. By RATS descriptors, distribution and internal enhancement patterns sometimes subjective. Technical limitations such as motion artifact, incomplete fat suppression, subtraction errors, limited temporal resolution can reduce kinetic accuracy. Hormonal background parenchymal enhancement, like cyclic changes, can mimic and obscure non-mass enhancement. MR-only lesions, Many non-mass enhancement findings have a no mammographic or ultrasound correlate, so biopsy required MR or contrast enhanced mammography guidance. Diagnostic clues. First, we have to assess the distribution of non-mass enhancement lesion, internal enhancement pattern, and adjunct imaging. Distribution could be focal, linear or linear branching, segmental, regional, multiple regions, or diffuse. Internal enhancement pattern could be homogeneous, heterogeneous, clumped, or clustered rings. Focal refers to confined area of non-mass enhancement, which is less than a breast quadrant volume. Linear or linear branching refers to enhancement arrayed in a line or a line that branches following breast ducts. Segmental refers to a triangular or wedge-shaped enhancement with its apex pointing towards the nipple. Regional refers to enhancement that involves large area of breast tissue, at least a quadrant. Multiple regions refers to enhancement in at least 2 large volumes of breast tissue, not conforming to the duct distribution and separated by normal breast tissue. And diffuse refers to enhancement distributed throughout the breast in a random fashion. Internal enhancement pattern may be homogeneous and refers to a uniform enhancement. Heterogeneous refers to non-uniform enhancement. Clumped refers to cobblestone enhancement or varying sizes and shapes resembling a bunch of grapes or string of pearls. Clustered rings refers to cluster group of thin rings of enhancement. So in cases of non-mass enhancement, we have to check the distribution and internal enhancement pattern. In a focal, diffuse, multiple, and symmetrical areas of non-mass enhancement with homogeneous internal enhancement pattern, usually often benign, and needs follow-up. While in cases of linear, segmental, regional, asymmetrical distribution with internal enhancement pattern of heterogeneous, clumped, or clustered rings, usually suspicious and consider biopsy. Adjunct imaging include diffusion-weighted images and ADC value measurements. So, low ADC, usually malignant. T2-weighted images, high T2 signal, usually favor benign lesions. Kinematic curves, persistence kinematics, usually benign. Plateau and washout kinematics, usually suspicious. Comparison with prior MR, stability versus progression. Consider hormonal timing, follicular versus luteal phase. Case presentation, case 1, 44 years old female coming for screening. She had a strong positive family history of cancer breast, her mother at age of 40s. Digital mammogram of both breasts showing extremely dense breast parenchyma with bilateral extensive punctate closely attached microcalcifications. So dynamic MRI was requested showing bilateral, multiple, almost symmetrical regional areas of non-mass enhancement on background of extensive fibrocystic disease seen in stair images. 55 years old, presented with palpable left axillary lump, confirmed on sonomammogram as a pathological axillary lymph node, pathologically proved metastatic of breast origin. Dynamic MR was done to detect the primary lesion, showing right breast upper outer quadrant, focal area of clumped non-mass enhancement with pathologically enlarged ipsilateral axillary lymph node. Female patient, 33 years old, presented with palpable left breast lump and bleeding per nipple. Digital mammogram of the left breast NCC and MLO view showing left breast lower inner quadrant, segmental area of pleomorphic microcalcifications. Pathologically proven high-grade DCIS. Further dynamic MRI was done to detect the multicentricity and bilaterality, showing left breast, lower outer quadrant, segmental area of heterogeneous non-mass enhancement extending anteriorly to the nipple. Female patient, 37 years old, presented with right breast hard palpable area with overlying skin changes. Dynamic MRI showing right breast upper outer quadrant regional area of heterogeneous non-mass enhancement associated with multiple ring-enhancing lesions, corresponding on T2 weighted images to areas of high, intermediate to high signal intensity with central areas of diffusion restriction. denoting abscess formation. Complementary ultrasound showing aggressive parenchymal pathological process with formation of multiple intercommunicating branching pockets of collections, some of them tracking toward the skin. Pathologically proven granulomatous lobular mastitis with abscess formation. 58 years old female patient underwent right breast conservative surgery and received radiotherapy 1 year ago. Came for follow-up. Dynamic MRI showing right breast upper outer quadrant faint focal area of heterogeneous non-mass enhancement at the site of operative bed with diffuse edema pattern of the right breast and diffuse skin thickening denoting post-operative changes. 44 years old female complaining of recently palpable hard right breast lump, showing dynamic MRI showing right breast outer quadrants, regional area of clumped non-mass enhancement, presenting low signal intensity in T2 with areas of diffusion restriction, histopathologically proven invasive duct carcinoma grade 2 with lobular differentiation. 37 years old female complaining of palpable right breast swelling, digital mammogram of both breast in CC and MLO view showing right breast upper outer quadrant, irregular shaped mass lesion with indistinct margin, and right breast 12 o'clock focal asymmetry. So dynamic MRI was done to assess the extent of the disease. Dynamic MRI showing right breast deeply seated, irregular shaped, heterogeneously enhancing mass lesion associated with anterior area of segmental area of heterogeneous non-mass enhancement. Biopsy revealed right breast invasive lobular carcinoma grade 2. 40 years old female with history of left breast conservative breast surgery, presenting recently with lumpy right breast sensation. Digital mammogram of the right breast in CC and MLO view showing dense breast parenchyma ECRC, and ultrasound showing multiple parenchymal areas of altered parenchyma. So MRI was done, revealed multiple right breast regional area of heterogeneous non-mass enhancement. Pathology revealed invasive duct carcinoma grade 2 with lobular differentiation. So, in practical workflow, confirm it's a true non-mass enhancement and exclude artifact, describe with PIRAT's lexicon, distribution and pattern, assess background parenchymal enhancement, correlate with mammogram and ultrasound, suspicious with no correlate, consider MRI or contrast-enhanced spectral mammogram guided biopsy, intermediate but benign leaning short-term interval follow-up. Take-home message, non-mass enhancement is one of the most challenging findings in breast MR. Careful evaluation of the distribution, better kinematics and adjunct imaging is the key. Red flags include asymmetrical, segmental, linear, regional distribution with heterogeneous, clumped or clustered ring enhancement, low ADC, progression on follow-up studies. When in doubt, biopsy is safest.
Thanks, Dr. Salwa, for a nice lecture. And now the next talker, Dr. Ahmed Rozek. He talk about vacuum-assisted biopsy. How can it reshape breast cancer management? دكتور احمد المحاضره دكتوره رشا طبعا بنهني حضرتك المؤتمر عاشر لبهيه دايما في باذن الله بالمجموعه كلها وحضراتكم جميعا طبعا الاكتوبر البينك اكتوبر بتاع الفيميلز دوت كل سنه وانتم طيبين حضراتكم جميعا.
Assalamu alaikum. Today we're going to speak about how VAP can change and reshape patient management. Real quickly, overview about the diagnostic pathway of a cancer patient that's breast cancer. First, we do imaging. We give a category, either Barrett's 4 or 5, and then we take a tissue biopsy. And this is usually done by core needle biopsy. What about VAP? When do we use VAP? And why do we use VAP? VAP is usually reserved for suspicious calcifications. Usually it's taken stereotactically, or B3 lesions like ADH or papilloma, which allows larger sampling and potential therapeutic excision. as well as small masses that are visible on ultrasound where we want to remove the whole lesion or we need a bigger sample, and also could be coupled with contrast enhanced mammography for contrast enhanced mammography guided VAP. Yes, the VAP procedure does take longer than the core needle biopsy, but it's a trade-off because if we don't do the VAP, then we'll have to do a surgery, which will take longer and it's more tiresome for the patient. Real quickly about the device and technique. This is the device that we have in Bahia, the Encore Aspire from Bard. As we can see on the screen itself, it gives us the whole 360 directional for to see which area you want to take the biopsy from, full or half notch. And this is obviously the driver in the hand. Obviously, this driver is much heavier than the normal biopsy needle, and it's much bigger. This is a real quick just animation of how the VAP actually works. It just opens and it sucks part of the tissue into the area that's open, and then it sucks it into the reservoir in the back. This is a real quick table. It's a big table, but just to highlight the important parts between the core needle biopsy and the vacuum. The core needle biopsy, we have to insert the needle multiple times, while the vacuum, we insert it only once. So like I said, 360 rotation. The sample size in the core biopsy is much smaller than the vacuum. The false negative rate in the core needle biopsy is much higher compared to the vacuum, but obviously the vacuum is much more expensive. Okay, we'll go through some cases where VAP helped us diagnose the patient correctly. This is the first case. This case with a 50-year-old female that presented for screening mammography. She presented with this area of distortion. It was non-palpable. She couldn't feel it. She just came for screening. And on ultrasound, this is its appearance. Again, area of distortion. We took a true cut biopsy as we normally do for anything that's seen on ultrasound. And it turned out to be mastopathy. Obviously, the imaging features are suspicious. So we went on and took VAP. And obviously it was seen on ultrasound, so we did an ultrasound-guided VAP. And it turned out to be sclerosing lesion radial scar, so it was for excision. And again, the wire localization excision confirmed the diagnosis of complex sclerosing lesion. So to recap this patient, the patient presented for screening. The mammal ultrasound findings described the non-palpable right breast area of distortion. The core needle biopsy showed mastopathy. The VAP showed radial scar or sclerosing lesion, which was confirmed by the wide local excision. This is a 56-year-old female presented for screening mammogram. As we can see that there is area of microcalcification that looks very suspicious. And even in our AI, it showed that it's very suspicious. The stereotactic core biopsy showed, was taken, and it showed fibroadenosis with calcification and no malignancy. Obviously, in the MDT, this was very suspicious calcification, so we asked for VAP, or they asked for VAP. So we underwent the VAP stereotactically, as we can see in these images. And this stereotactic VAP turned out to be fibroadenosis with no calcification, so confirmed the diagnosis, and the patient pretty much didn't need anything else. Again, just a recap, and again, the patient didn't need surgery, so instead of, in another case, if we didn't have VAP, this case we would have had to put a wire to remove the lesion, and it would have turned out to be fibroadenosis. So obviously the whole operation and the complications of the operation, she would have to go through that. With the VAP, we didn't have to do that. This is another case. This is showing you that she stayed, this is case number 2 still. It showed us that from 2021 to 2025, the calcification stayed stable, and it just decreased a little bit because of the VAP that we did. Case number 3 is a 48-year-old female that presented for screening mammogram. As we can see, there's area of microcalcification and a linear distribution that looks suspicious. Stereotactic core biopsy. It was inconclusive for larger biopsy, or like you can see, excision. So obviously we went for the larger biopsy, which is VAP. And it turned out to be invasive duct carcinoma grade 3. Again, this is all repeating ourselves that the calcifications are always better taken by VAP to avoid delaying the patient. This is a 62-year-old female patient that presented with a lump, as we can see, that's deeply seated in the left breast. But on further examination, she has a small area of very small, minimal sized calcifications that are seen anterior to the lesion. In this case, we went for stereotactic VAP right away. We didn't do true cut biopsy because of the small size. And obviously, because we removed it completely, we put a clip, and it turned out to be DCIS. And we did wire localization excision. So when we excised it, the wire guided lesion, that was the anterior lesion, it turned out confirmed diagnosis of DCIS, and obviously the lesion in the back was invasive duct carcinoma. So in this case, the patient did 2 wire localizations instead of missing the other lesion or incorrectly diagnosing it by taking true cut biopsy and then having it developed a mass later on. Case number 5, it's a 37-year-old female patient presented with newly developed bleeding per nipple. She had a regional area of microcalcification that looked suspicious. She did a nipple cytology and turned out to be interductal papillary lesion with focal mild atypia. We did contrast enhanced mammography. This patient actually was for MRI, but she didn't tolerate the MRI, so we did contrast enhanced mammography. And the same area that had the calcification had an area of non-mass enhancement, as we can see. We did VAP, and this is the sample for the VAP. It's much larger, as we can see, compared to what I showed you before from the stereotactic guided. And this turned out to be DCIS. This person simply did skin-sparing mastectomy. Okay, case number 6. This is a 44-year-old female presented with newly developed calcifications that progressed over time. As we can see from 2021, 2023 started to develop the calcifications, 2024, and then 2025. This is the comparison between 2021 and 2025 that actually did newly develop. So we went for stereotactic guided biopsy, and it turned out to be ADH. Obviously, ADH is something that we have to take seriously, and we underwent VAP. And this is the VAP that we did. As you can see, the area, the very characteristic vacuum that happens from the VAP. And this is the sample. And it turned out to be DCIS. We did wire localization and excision of the area. And it turned out to be duct carcinoma in situ, cribriform solid, and micropapillary type. Just to recap, the patient for annual mammography, and she had developing microcalcifications. The coordinated biopsy turned out to be ADH for larger biopsy, the VAP DCIS, and also confirmed by the wire localization. Obviously, we can't leave the DCIS. So again, calcification always better taken with VAP. Case number 7, this is a 40-year-old female presented with a palpable lesion in the right breast. This is how it looked like on ultrasound. The ultrasound true cut biopsy turned out to be fibroadenosis. Yet because of how suspicious it looked on her initial imaging, we went for contrast enhanced mammography. It corresponded to a focal non-mass enhancement. We underwent ultrasound guided VAP because again it was seen on ultrasound. And ultrasound guided VAP turned out to be PASH. So to recap, this patient presented with a palpable lump by coordinated biopsy turned out to be fibroadenosis, but because of its suspicious criteria on the mammogram, we went for contrast enhanced mammography to characterize the lesion and further guide the next steps. The VAP turned out to be PASH, so therefore she's on follow-up. Again, in the last case, we avoided doing operation, obviously. 42-year-old female diagnosed as right breast cancer, invasive duct carcinoma, as we can see in this contrast enhanced mammography. There's another small enhancing lesion that's posterior to the original lesion. Is it multicenteric or not? Stereotactic contrast enhanced mammography VAP. We can see these images. We targeted the posteriorly enhancing nodule. And it turned out to be a small intercanalicular fibroadenoma. So therefore, it's not multicenteric. So this patient's management had changed from possibility of MRM to conservative breast surgery. This is another 41-year-old female diagnosed with right breast cancer, upper outer quadrant, invasive lobular carcinoma grade 2. And on MRI, she had another enhanced nodule that's more anterior. Is it multicenteric? Same question. This is how it appeared on second look ultrasound, as we do routinely in Bahia if needed. Turned out to be a hypoechoic lesion, as we can see. We took ultrasound-guided true-cut biopsy, and it turned out to be fibroadenosis. So we did contrast-enhanced mammography VAP. We targeted the anterior located nodule that was appeared on ultrasound, on MRI, I'm sorry. And the stereotactic contrast-enhanced mammography turned out to be fibroadenosis, not multicenteric. So the patient just simply did wire localization excision of the posterior enhancing lesion that's seen in the right breast. So to summarize real quickly, the VAP is usually reserved for suspicious microcalcification, and it has a very high yield in suspicious microcalcifications, as well as the B3 lesions and small masses. And as we can see in the last two cases, when it's coupled with contrast-enhanced mammography, it solves a lot of problems that a lot of nodules don't appear unless enhanced. And again, the VAP does take a little bit longer. The VAP procedure itself takes around 30 minutes from start to finish. In comparison to the contrast to the needle biopsy, it just takes around 10 minutes when you start. But that, in the long run, avoids the patient going into surgery. Thank you.
Thank you, Dr. Ahmed, for this nice presentation. We'll move to the next speaker, Dr. Mohammed Mohsen. The talk with metastatic workup in breast cancer, when, which modality, and whom, for whom.
Hello. This is the metastatic workup in breast cancer, which will begin with the introduction. We'll begin with the introduction and the clinical pathway where the metastatic workup fits. It begins with an initial diagnosis, staging, and management. The key notes here is that the workup is tailored by stage, receptor status, and symptoms. And the aim is to detect actionable metastases before irreversible systemic spread. This table summarizes the different pathways of spread of different subtypes and hormonal profiles of breast cancer. The invasive ductal carcinoma has a classical spread with a high FDG uptake, so PET-CT is reliable, while the invasive lobular carcinoma tends to have a peritoneal, GIT, and ovarian leptomeningeal metastases with a characteristic low FDG avidity, so MRI is preferred, as PET-CT may underestimate. Whereas the luminal A has a propensity for bone more than visceral metastases with a characteristic osteoplastic metastases and low FDG avidity. It has an indolent course, so bone scan, MRI, or fluoroestradiol PET is preferred. Luminal B has a propensity for bone as well, but mixed lytic and sclerotic with moderate FDG uptake, so the PET-CT is useful. Where the HER2 enriched has a propensity for CNS metastases with a high FDG uptake, so we should add an MRI brain at baseline assessment. The triple negative is a quite aggressive tumor with a very high FDG uptake and necrotic lesion, so PET-CT here is ideal for short-term interval follow-up. Other rare types include basal, mucinous, and metablastic carcinomas. We should point that the mucinous carcinoma has a very low FDG uptake, so MRI is also better here than PET-CT. The definition of an oligometastatic disease, it is an intermediate state between localized tumor and widespread metastatic disease with less than or equal 5 metastatic lesions in less than or equal 2 organs. It is amenable for local curative intent therapy, but requires MDT evaluation. It can be synchronous or oligorecurrent. The overall survival improves when local ablation complements systemic therapy in selected cases. And the next step is that we should stage with PET-CT plus or minus MRI to present to MDT for localized management planning. We should also be able to differentiate the visceral from the osseous metastases as the visceral metastases have a rapid growth rate and subsequently a poorer prognosis with obviously different management. So the next step here, we should always acknowledge whether it's negate or acknowledge whether metastases are visceral or osseous or both, whenever possible. And we should adjust imaging follow-up according to disease type. This is a modality-based approach, and this table summarizes different modalities when to use and the primary purpose with limitations. We should begin with the indications for staging. Stage 1 and 2A, we should do a local imaging only. Stage 2B and 2-4, we add systemic staging. High-risk biology such as triple-negative, HER2 positive, which report in CNS and visceral screening. Equivocal lesion we may confirm by biopsy or functional imaging before therapy. I would like to point out some limitations. The CT chest, abdomen, pelvis had a very low sensitivity for marrow and small peritoneal lesions, while the bone scan detects osteoplastic metastases, misses lytic, and early marrow disease. FDG PET has a low sensitivity for less than 1 centimeter, ER positive, lobular and mucinous tumors, and we should use fluoroestradiol PET for ER positive. MRI of the liver may miss tiny capsular lesions. MRI of the brain is the gold standard for CNS metastases. What about the biopsy indications? It's a problem solving of indeterminate lesion, isolated or discontinued lesion compared to bioimaging, re-evaluation of receptor status. We should perform an image-guided core biopsy and update receptor profile before changing therapy. Avoid diffuse metastatic disease with clear radiologic pattern. PET-CT indications includes baseline staging in stage 3 and 4, but limited by cost and availability. Suspected recurrent disease, rising tumor markers with negative conventional imaging, problem solving when CT or MRI are equivocal in certain situations, but after excluding the PET-CT limitations. Oligometastatic planning. FDG PET-CT identifies occult disease, prevents future surgery, and quantifies metabolic tumoral burden. There are a lot of false positives in PET-CT, such as the inflammation, granulomatous disease, post-radiation, some benign bone conditions, and bound fat and benign tumors. While the false negatives in PET-CT includes a small lesion size, such as lung micrometastases and small nodes, which will correlate with diagnostic CT or ultrasound in lymph nodes. Low FDG avid histology, which should consider MRI a contrast CT guided by the subtype. CNS and liver metastases have a high, because of the high physiologic background uptake, which may mask lesion. In both, we should use MRI with contrast for evaluation. While the sclerotic bone metastases has a low tumor cellularity, we should use bone scan and MRI for better detection. Post-therapy effects, such as metabolic stunning after chemo or hormonal therapy, we should repeat PET after recovery period. Some key considerations include that the lymph nodes, PET-CT detects disease beyond conventional boundaries, but it lacks histologic specificity. I'd like to discuss a case, a 63-year-old with a left breast cancer presenting for metastatic workup. CT chest abdominal pelvis revealed the right hilar hyperdense lesion, suspicious of necrotic lymph node, and no other metastases were found. PET-CT was ordered as a problem-solving modality. PET-CT revealed metabolically inactive right hilar lesion, hyperdense lesion, and the diagnosis was proposed to be a benign bronchogenic cyst. This is a 64-year-old with right breast cancer presenting for initial staging PET-CT, which showed enlarged FDG avid, right paratracheal, bilateral hilar, and other mediastinal lymph nodes. The differential diagnosis include metastatic disease, sarcoidosis, and lymphoma. Core biopsy was done and revealed sarcoidosis. This is an example of a false positive in PET-CT. An organ-specific approach where the lung metastases, as mentioned, that the PET-CT sensitivity decreases for nodules less than 1 centimeter, and high-resolution CT is the mainstay for diagnosis and follow-up. What about the next step? If less than 5 millimeters, single or multiple, follow-up in 6 to 12 months. 5 to 10 millimeter, single, 3 to 6 months follow-up, multiple, 3 months follow-up. More than 10 millimeter or FDG avid of a single chip biopsy to exclude second primary. More than 10 or FDG avid multiple should be considered metastatic and proceed for systemic staging and therapy decision. Of any size, cavitating or atypical, exclude infection first, then consider biopsy. The liver metastases that the MRI detects early infiltrative metastases missed by CT. And the key interpretation point here is that the hypovascular metastases may appear isointense on early phases, which should depend on diffusion restriction and delayed enhancement. We should trick this current algorithm for a common clinical scenario where a hepatic focal lesion is detected as FDG avid on PET-CT. What to do next? Exclude other distant metastatic sites, then proceed for dynamic MRI to assess the true tumoral burden. If it's more than 5 lesions, we may aim for palliation. If it's less than or equal 5 lesions considered oligometastatic, we may aim for cure. Both may act as a baseline for follow-up, and all of this is, of course, diagnosed or decided by the MDT. What about bone metastases? We already discussed the imaging characteristics. The important next steps here is equivocal solitary lesion. We should proceed with MRI with diffusion, PET-CT, or CT-guided biopsy. We may use a fluoroestradiol PET-CT in ER-positive tumors. This image highlights the difference between fluoroestradiol PET and FDG PET in highlighting the osseous metastases in an estrogen receptor in an estrogen ER-positive neoplasm, malignant neoplasm of the breast. We can see here that it's very obvious in the fluoroestradiol PET. The brain metastases, we've already discussed its key concepts. Its indications include new neurological symptoms, HER2 positive or triple negative subtypes. What about the next step? If a solitary lesion may proceed for neurosurgical or stereotactic radiation surgery. If multiple, we may proceed for whole brain radiotherapy or targeted systemic therapy. We should take care of lesion numbering upon reporting MRI brain metastases. The adrenals, I like to call them common and rare. What's rare is that the metastases from breast cancer are extremely rare, often occur in disseminated disease, while adenomas are very common overall. We should check the next algorithm. If an adrenal lesion is detected on initial CT, which measures the Hounsfield unit in pre-contrast CT, if it's less than 10 Hounsfield unit, consider it benign. Proceed for follow-up, keeping in mind the collision tumors in the future. If it's more than 10 Hounsfield unit, assess for widespread visceral metastases. If yes, consider it metastatic and follow-up. If no, or only osseous metastases, you should perform an MRI in and out phase and CT adrenal protocol if needed. If it's suspicious, biopsy to exclude second primary. If it's not suspicious, you should proceed for follow-up. The take-home message is here is that the radiologist's role extends beyond detection to guiding precision therapy. You should treat the patient as one piece, not in pieces. Think twice before dooming the patient metastatic. MRI and PET complement rather than compete. Always correlate functional with morphologic imaging. You should know that the imaging divides while the management unites, and in between, the MDT decides. I'd like to thank you all for being such a good audience.
Thank you, Dr. Muhammad, for your very informative presentation. And now our last presentation, post-operative breast cancer surveillance, how to solve diagnostic dilemma. Dr. Niveen.
Bismillahirrahmanirrahim. Post-operative breast cancer surveillance, how to solve the diagnostic dilemma. Let's proceed with some cases. First case, 64-year-old female patient underwent right mastectomy for invasive ductal carcinoma presenting for follow-up. Her mammography revealed scattered fibroglandular breast parenchyma, ACRB, with no left breast spiculated masses or microcalcification. However, her ultrasound revealed a right MRM scar with an irregular speculated hypoechoic lesion at the medial end of the scar with internal cystic changes. We proceed with MRI, and the MRI revealed the medial aspect of the mastectomy bed showing irregular lesion displaying low T1, intermediate to low T2, and a high stir signal. And on post-contrast series, it shows moderate heterogeneous non-mass enhancement. And such non-mass is seen deeply infiltrating the underlying chest wall and abutting the underlying pleural. We also have a right axillary operative bed faint enhancing nodule confirmed by second look ultrasound as an axillary lymph node. So our opinion in this case was a status post-right MRM showing operative bed suspicious enhancing lesion by RADS5 with no left breast enhancing lesions by RADS1. And the pathology report came with recurrent invasive ductal and lobular carcinoma grade 2. So in this case, MRI confirmed the mastectomy bed recurrence, detected the chest wall infiltration, and excluded contralateral lesions. Case number 2, 71-year-old asymptomatic female patient underwent right conservative breast surgery for invasive ductal carcinoma grade 2, presenting for post-operative follow-up. Her mammography revealed right breast post-operative scarring and diffuse edema pattern. And the complementary ultrasound revealed right breast operative bed scar with no suspicious lesion, with diffuse edema in the form of skin thickening, echogenic fat lobules, and interstitial edema lines. Contrast enhanced mammography was done and revealed no enhancing lesions by RAS2. Our opinion in this case was right post-operative changes proved on follow-up also by RAS2. And in this case, both sonomammogram and contrast mammography confirmed that there is no operative bed suspicious lesions and excluded contralateral lesions. Case number 3, 59-year-old female patient underwent right conservative breast surgery for invasive ductal carcinoma, presenting for follow-up. Her mammography revealed right diffuse edema pattern in the form of coarse trabeculation and diffuse skin thickening owing to previous surgical intervention with left upper outer quadrant intramammary lymph node and also retroareolar tubular densities. Complementary ultrasound revealed left upper outer quadrant intramammary lymph node and left dilated retroareolar ducts with echogenic non-vascular secretions. However, on the right side, we have right breast post-operative changes, and also we have area of altered parenchyma mounting to mass formation with mixed echogenicity, seen at 12 o'clock with no vascularity on color duplex application. And it was categorized as BIRADS 4A. Biopsy was performed and the pathology report came with fibrocystic changes negative for malignancy. So we have here pathological radiological discordance, so we proceed with MRI before rebiopsy. Her MRI revealed right post-operative therapeutic changes in the form of diffuse skin thickening with underlying diffuse breast interstitial edema of bright T2 and stir signal intensity. We also have a right upper outer quadrant 12 o'clock area of altered parenchyma and mixed signal intensity, displaying low T1, intermediate T2, and high stir signals, with a well-defined lesion of dropped stir signal with REM enhancement on post-contrast series, denoting area of fat necrosis. Our opinion in this case was a status post-right conservative breast surgery showing right breast post-operative changes with right breast 12 o'clock post-operative scarring and zone A area of fat necrosis, which also proved on follow-up, with no left breast enhancing lesion. So in this case, MRI confirms the diagnosis of operative bed fat necrosis and excluded operative bed recurrence and contralateral lesions. Case number 4, 36-year-old female patient underwent right conservative breast surgery for invasive ductal carcinoma presenting by palpable mass with history of previous left lumpectomy. Her mammography revealed right diffuse edema pattern in the form of coarse trabeculation and diffuse skin thickening, and right upper quadrants ill-defined dense mass. Her complementary ultrasound revealed the right breast edema as well as the right breast palpable irregular hypoechoic mass lesion extending from 10 to 2 o'clock. MRI was done and revealed right post-operative changes as well as a right operative bed irregular mass of mixed signal intensity displaying low T1, high stir signal with diffusion restriction, and on post-contrast series showing intense heterogeneous enhancement with central non-enhancing areas denoting central areas of breaking down. Our opinion in this case was the status post-right conservative breast surgery with operative bed suspicious pathological mass enhancement, likely operative bed recurrence by RAS4 with no left breast suspicious lesions. And the pathology came with invasive ductal carcinoma with focal mucinous component grade 2. In this case, MRI confirms the diagnosis of operative bed recurrence, excluded contralateral lesions. Case number 5 and the last case, 50-year-old female patient underwent right conservative breast surgery for invasive lobular carcinoma presenting with right breast palpable lump. Her mammography revealed right retroareolar focal asymmetry with upper outer quadrant ill-defined hyperdense mass lesion. And ultrasound revealed right upper outer quadrant ill-defined antiparallel mass lesion with operative bed seroma with no left breast lesions. Contrast mammography was done and revealed right upper outer quadrant enhancing mass lesion with left retroareolar enhancing mass also. So our opinion in this case was status post-conservative at the right side with operative bed suspicious pathological mass enhancement, likely recurrence by RAS4, with left breast retroareolar suspicious enhancing mass also by RAS4. And the pathology came with bilateral invasive lobular carcinoma. In this case, both sonomammogram and contrast revealed operative bed recurrence. However, sonomammogram couldn't detect the contralateral newly developed lesion, which was detected by contrast. So, post-operative breast cancer surveillance. We have common trends in breast surgery like modified radical mastectomy, which was for the past 40 years considered the standard surgical treatment for locally advanced invasive and inflammatory breast cancer. Local breast conservative therapy, the goal is to combine complete tumor removal with preserving the shape and the appearance of the breast, which is multifactorial, depends on size and position of the tumor in relation to size of the breast. We have a skin-sparing mastectomy and nipple-sparing mastectomy, which we have interaction between conservative techniques and radical surgery with overlying skin flap as well as nipple area complex are preserved. We have also breast reconstruction surgery like immediate breast reconstruction, volume displacement technique, volume replacement techniques, and contralateral procedures. So what's protocols for post-operative breast cancer surveillance? We have two imaging questions. What is the best imaging modality and regimen to monitor for the recurrence and or newly developed lesions? And what factors should be considered to determine the further management? Mammogram. Up to now, mammography has been the only evidence-based imaging modality for detecting asymptomatic recurrence or newly developed lesions. Ultrasound, MRI, and contrast mammography have been used to increase detection of recurrence and newly developed lesions at an early stage. Ultrasound detects ipsilateral recurrence or contralateral lesions with higher sensitivity than of mammography alone, and it's an excellent modality to evaluate the axillary areas. MRI shows high sensitivity and specificity for differentiating between post-operative or post-treatment changes in the breast from recurrent malignancies. And contrast can differentiate between benign intervention complication and early local regional recurrence of breast cancer. It's used to enhance the sensitivity of conventional mammography and exclude residual or recurrence malignancy in patients with post-operative therapy or surgery changes. Let's see common post-operative mammography findings. We have fat necrosis, increased breast density, especially with edema, skin thickening, architecture distortion, either for operative bed scarring or in suspicious lesions, calcifications, which may be microcalcifications or macrocalcifications. Common post-operative ultrasound finding, we have skin thickening and post-operative edema also. Operative bed seromas, fat necrosis, operative bed recurrence. And common post-operative MRI findings may be benign post-operative MRI findings as edema and architecture distortion due to scarring, hematoma with the signal of blood, seroma, either infected or non-infected seromas, fat necrosis with dropped stair signal. And also we have suspicious postoperative MRI finding like BIRADS4 lesion, low to moderate probability of being malignancy as this nodular enhancement inside the seroma and this non-mass enhancement, segmental non-mass enhancement. And also we have BIRADS5 with high probability of malignancy as this enhancing mass lesion at the site of the previous conservative breast surgery scar. And postoperative contrast enhanced mammography as a general guideline is used as an adjunct following mammogram and or ultrasound examination to localize a known or suspected lesion. Iodine contrast agent behave similarly to the gadolinium contrast in breast MRI. So our take-home message, an important perspective is that the standard modality for the initial assessment of the postoperative surveillance for breast cancer is mammogram, with or without complementary ultrasound. However, conventional methods have been known to be suboptimal in accurate assessment of certain cases of postoperative breast, either symptomatic cases or cases with sonomammographic suspicious finding. So further contrast-enhanced breast imaging evaluation is required. The choice of surveillance with MRI or contrast in women with a personal history of breast cancer requires optimal patient selection. This should be recommended according to identified sonomammography or clinical finding. It also should be tailored according to the type of operation, breast density, availability of the modality. Contrast is a promising tool for increasing sonomammography sensitivity, improving size estimation and staging with a performance comparable to that of MRI, yet more available, less expensive with less examination time. However, MRI is the exam of a choice whenever we have mastectomy bed recurrence in deeply seated lesions or lesions located at mammographically hidden areas. And it's also superior in detecting of postoperative changes as operative bed seromas or fat necrosis. Thank you.